and good to have you with us in the 9 p.m. edition of the Urban Debate. Because much is being said about the Maharashtra's method of tackling COVID, especially the Mumbai model. And it's not just me who's saying this, it's actually the biggest of the institutions in our country. The Maharashtra's way in the Mumbai model was something that was referred to by the central government in its recent press briefings. And this is something that you don't see often in our country, where some measures taken by an opposition-governed state are actually mentioned and appreciated, but it happened. The same was actually also mentioned in the court. While talking about the measures being taken and the state of COVID, it was said that we should look at what's being done here. An exhaustive report has also been done by IISc Bengaluru on this model and how it has worked and helped saving lives. And I'm going to come to that in just a bit. But if you're wondering why I'm talking about this today, let me tell you the data that's just come in for Mumbai, the COVID cases data. New cases, 1,798 in the last 24 hours. Recovered cases, 6,082. It's one of those days where our recoveries are 3.3 times the daily cases. This is a great sign. Since Mumbai began to show a turnaround, we've been extremely cautious. We've been very skeptical. We've also looked at the testing data, which, by the way, is still reducing. So, yes, while Mumbai's daily cases are coming down, its testing data is also coming down. But largely, there are many indicators between positivity rate and others that show you that we are moving in the right direction. And something that has been done here has worked. So tonight I want to talk about that. I want to talk about this Mumbai model. I want to talk about the fact that Maharashtra went early into implementing curbs and then tougher curbs until we finally reached a lockdown-like situation much before the rest of the country, and whether that helped us. And I want to talk about this because there are still many parts of our country which are in a bad state, which are actually now beginning to see disaster hit them. And if there are lessons that can be learned from this system that was implemented here, then we must highlight it. We must talk about it. What we did that was right, what we did that was wrong, what can be implemented elsewhere. These must be discussed. Let me begin by another data that we've pulled out. We looked at the lockdown dates or the lockdown-like restrictions being implemented dates and the positivity rate at that point of time in these states. It also shows you how Mumbai actually and Maharashtra actually moved very quickly. Mumbai went into a full lockdown when its average positivity rate was 17%. Delhi, and because this question is often asked, why is it that Delhi's nightmare has gone on for much longer and it has been much more intense than what Mumbai saw in its worst days of the second wave? Delhi went into a full lockdown when the average positivity rate was 26.4%. 26 people out of 100 were testing positive. That was the positivity rate. Bengaluru went into a full lockdown when the average positivity rate was 39.2% for the week. And actually on that day, it was 51% in Bengaluru when they finally decided to do this. The IISc report says because we brought in curbs timely and we implemented tough curbs and did several other things, we've managed to save 19,000 lives in this state. Measures have saved 19,000 lives in the state of Maharashtra. Surely there is a lesson to be learned there. The state has escaped additional burden of 38 lakh cases. Surely there is a lesson to be learned here. Without wasting any more time, let's quickly get to it and say good evening to the panelists who are joining us right now. Dr. GAUTAM BHANSALI, consultant physician for Bombay Hospital, chief coordinator for all private hospitals in Mumbai in this COVID battle. Dr. SUNEELA GARG, professor of excellence community medicine, Maulana Azad Medical College, member of the Lancet Commission COVID Task Force in India. Dr. ANOOP, Chairman for Geriatric Medicine, Manipal Hospitals, member of the Critical Care Support Unit for the Government of Karnataka, and Dr. SHASHANK Joshi, Dean Indian College of Physicians, Leelavati Hospital, member of the Maharashtra COVID Task Force, also joining us right now. Let me first start off with Dr. Bhansali. Dr. Bhansali, for those who are not very well aware of, some of the systems that we put in place in Mumbai, do tell us. Tell us what this Mumbai model is that you think has proven helpful in cutting down the spread of infection.
Yeah, Tanvi, first of all, through your channel, I would like to congratulate the city of the Mumbai and the citizen of the Mumbai that we are definitely achieved the target what we wanted. First of all, we created two, three things in Mumbai. One thing was with the help of the municipal commissioner and with the help of the government, we have created ward war room. That was our game-changing theme in Mumbai, that ward war room. We have divided Mumbai in 24 ward, and in each and every ward, we have see earlier there was a one disaster control room where was all calls was diverted to the disaster control room only. Then what we decided that the city is such a big and it's a densely populated city, and if number of cases increase, then in that case we need decentralized system, and in that way we have created this ward war room. Mumbai, we divided Mumbai in 24 ward war room. Out of that, in each and every ward, we have deployed at least 10 MBBS doctor to take care of the citizen of the Mumbai. In each and every ward, they keep calling to the person who was COVID positive. They ask to the person or people that whether they have any symptom, mild symptom, they need bed in the hospital. Then that was the duty of the doctor in the ward war room to allocate bed in whether in a private hospital or government hospital or nursing home or jumbo center. One thing that what we have decided about that thing. Secondly, since I am the chief coordinator for all private hospital in Mumbai, so we have taken a conscious decision that no private hospital will directly admit patients. See, earlier there was a problem that each and every hospital was just taking two bed for their own staff or there's some VIP movement or something like that. So because of that, we are having total 45 private hospitals. So because of two bed in each hospital, there was approximately 100 bed was vacant every day for the some their own staff or something like that. So we have created one thing that no private hospital will directly allocate their bed for the patient or for anybody else. So all private hospital was also ready for that. Each and every patient who is admitted in the hospital, private hospital also, it will be through the ward war room only. If some patient who is suddenly having breathing difficulty or some serious problem, if he directly go to the hospital casualty, then private hospital can admit that patient, but he has to inform to the ward war room, and immediately that dashboard will be corrected. Dashboard has to be corrected, or dashboard has to be updated every hourly. That is the only city in the world who updated their dashboard every hourly. So these are the two, three things. And third thing was our chase the virus policy. See, as I told you earlier also that Mumbai was the first city who decided that you don't need doctor prescription for testing. So we have done testing like 50,000, 60,000, 70,000 today, 40,000 testing. Whoever wants to go for the testing, you can go and you can do the testing. So because of that model, like chase the virus policy model, asymptomatic patient no need to admit in the hospital, and ward war room creation, which was the basic thing for Mumbai, that helped us a lot to allocate bed, smooth allotment of the bed. And I'm telling you one thing, that no patient died because of not availability of the bed in private or government hospital. That is Mumbai. So these are the few things which helped us a lot. And second thing, contact tracing, testing, and tracing. That was the basic model in Mumbai we have adopted, and because of that, now situation is this.
Yes, absolutely. And one very important thing that you spoke about was, of course, decentralized war room system that made the system faster, more efficient, and the bed allotment process a lot more simpler. I mean, this is not to say that during the peak time there wasn't, struggle and pain in terms of trying to get a bed and a lot of running around. But there was a lot of experimentation and changes and fine-tuning of the policy that actually finally led us to the system that seemed to have worked and reduced the pressure. Dr. Suneela Garg, the other concept that's much spoken about when it comes to what Mumbai did and other places have now begun to do is triaging. Could you help us understand what does this mean and how does this simplify the whole admission process?
See, basically, Tanvi, triaging means as soon as the person presents to the hospital setting with or any of the peripheral healthcare setting with any of the symptoms, influenza-like illnesses or severe acute respiratory infections or any symptom which looks like COVID, these persons are isolated immediately and then they are, looked for COVID and then accordingly the action is taken. So that's where is the immediate action which will prevent spread to others and the case is also appropriately. So this triaging we are following in cases of these pandemics and we are following in cases of disaster also. So as to early isolate these individuals and take the action appropriately so that other people do not get infected.
Okay, to your mind as well, before I bring in other panelists, what is it that Mumbai attempted to do that we can look at replicating in other cities as well, Dr. Garg?
Yeah, definitely. You see, this is a very, very important question. One is always have a decentralized approach, people-friendly approach. That means you to see this approach was friendly. Everybody, rich or poor, had an access. That is one thing. Second part is that they had testing, treating, and tracking. That strategy went. It has got a Mumbai model has got 5-pronged strategy, which has got much more, and they did oxygen supply management so very appropriately. Another part is that they also implemented the preventive measures also when we talk of masking. So that strategy also went ahead. So overall, Mumbai model had a public health perspective. That's how today we have got 1,700 cases, and also our positivity is somewhere around 7%, which is a very good strategy. And in your show only earlier we saw that yeah.
Yes. We had lost the audio with you in between, but go ahead, finish your point now. I can hear you.
Yeah, so that's what I was telling. It has got with a 5-pronged strategy, which is a decentralized approach, the making of the war rooms in different wards. The third part is, there is no preference to rich or poor and private or public. Everybody gets a bed. That is important. And the fourth important part is testing, treating, and tracking. And they also kept watch of preventive measures. So, it was a kind of a holistic approach which was linked to, management of pandemic as a whole. So the city responded together in unison to this whole strategy.
Okay, fair enough. Let me also bring in Dr. Shashank Joshi on this conversation. Dr. Shashank Joshi, the other aspect, one of course has been, and we'll talk a little bit more about, the systems which are put in place for treatment, admissions, bed allocation, tracking, testing, but also the way Maharashtra and of course the city of Mumbai moved in terms of implementing restrictions. And I think even before we announced the full-fledged lockdown-like restrictions, we had already for 2 weeks prior to that brought in pretty much a lot of other curbs as well. Do you think that timely movement helped us and is something that the other states probably move later with, and that's why they are still looking at higher number of cases?
Absolutely, Tanviji. I think there are two things which were the circuit breakers or the chain breakers. The first thing was that Mumbai got restrictions quick and fast because we were completely overburdened. I don't think that whatever we may have it on theory, in the first week of April and second week of April, there was like a mayhem. Let me be very honest that, of course, it was a decentralized approach, but there was a tremendous strain on the infrastructure. But really, if you ask me what saved the light for Mumbai are two things. Number one is we had a large jumbo strengths in beds, which were like a buffer. So a lot of people who were asymptomatic or mild disease were able to be cushioned there. That gave us the cushion because this time the pandemic in the second surge was in the middle class and the neo-rich class. And everybody wanted a private bed. Private beds were very difficult to get. And nobody wanted to go to a public hospital. So the jumbo served as a perfect buffer there. And also if they were asymptomatic, they could be digitally connected with their doctor. And the five-star hotels were also opened up so that a hospital bed was not wasted. So rationalization of hospital beds at the peak and restrictions being put almost 2 to 3 weeks early probably were the big game changers, apart from, of course, better management. And the third thing which also probably bailed out Mumbai is a very strong oxygen audit, apart from having various medications in place. You see, every jumbo, every public hospital had all the medications in place. In fact, there were times when private hospitals struggled to get the medications. And I think following up of treatment protocols with that probably helped in the long run. So I think it was a combination of everything, not only just the decentralized approach, the assess triage, chase the patient policy. Last year, the policy was chase the virus. This year, the policy was chase the patient. So there were patients where wardroom used to send an ambulance to their house, pick them up and take them either to a corona care center or a public or a private hospital, which was, according to me, amazing. But I think what saved the light for Mumbai, predominantly at the peak time in the first week of April, were two things. The buffer capacity created by jumbo facilities that gave us that little extra cushion we needed at the peak. And second, probably the constant supply of medication and oxygen. And as I said, that this was something, and the restrictions definitely kept coming in 2 to 3 weeks early, made a big, big dent. And that's why we are seeing a reasonable dent today.
I want to, before I go across to Dr. Anoop, just ask one follow-up on this, Dr. Joshi, to you, because we've also looked at the testing data. And from what we were doing in, say, first week of April and March end, which was when cases were hitting through the roof, we've seen a significant drop in even the testing numbers of Mumbai. Now, of course, a lot of it will have to do from the fact that we are indoors, we are not stepping out, so fewer people are perhaps getting them tested as well. But should we also take our daily case count with a pinch of salt, then the positivity rate with a pinch of salt, to say, because we are even testing lower right now?
No, Tanvi, I won't agree there. I will tell you the statistics very clearly. In the last week of March and first week of April, which stretched, Mumbai city at its peak last year could never test more than 20,000 cases. It went maximum to 22,000 tests per day. See, the molecular labs have not grown. If you ask me, we have not added more capacity in molecular labs. This time we stretched those labs, and on the peak days, they stretched up to 50,000. And then what happened is, for the test appointments, it took 2 days. For the results, it took 2 days. Means indirectly, they were still doing around 25 to 30,000 cases. That's the max they can stretch out to. So obviously, we need to build more testing capability in Mumbai city. It's still work in progress, if you ask me transparently. So what was happening is, in that time, we were testing 40 to 50,000 cases. We had a lot of symptomatic cases, and a lot of repeats were happening. Now what has happened is, there is a drop in the number of testing, but the test positivity rate, which was at 30% there or 28% there, has come down to around 5, 6 or 7%. Also remember that ICMR changed its testing strategy. We are not doing repeat tests anymore. We are not doing the screen tests anymore. So obviously, when all those testing strategies have been dropped down in the last 1 week, and we have always followed the ICMR norm, there has been a natural drop. But there is a stretch of saturation threshold. Maharashtra cannot do more than 2.5 lakh tests unless and until we add the CRISPR technology, we add some rapid diagnostic technology, but RT-PCR saturation, and Mumbai always had 70-80% of the tests coming from the molecular diagnostics, which is the RT-PCR. And RT-PCR, Mumbai city can safely do maybe 25 to 30,000 when it is stretched. Beyond that, it will be all rapid antigen. So the stretch threshold is there. Right now, we are definitely on the wane. Test positivity data, doubling time data clearly shows us very clearly that from 30 days doubling time, now we are up to almost 120, 130 days doubling time. The test positivity rate at 28-30% is down to this. So clearly there has been a drop in number of tests, but that doesn't worry me because overall the test positivity rate has come down. But we need to understand that we cannot stretch beyond a saturation point. See, if the number of tests which Mumbai can perform at its peak is finite, We can't go above that, na, Tanvi. So that is what we need to build. Suppose
Correct.
we are going to anticipate a worse wave than this, which is unlikely to happen because we need to saturate our population with vaccination. Then we need to, from 25,000-30,000 tests, actually have 40,000-50,000 tests. So that's a lacuna or a limitation Mumbai has, and Mumbai is mindful of it. And that's why we have to look at innovative technologies like CRISPR technology, which is a 1 or 2 hour test. Then, the CSIR has loaned us this dry swap technique where the RNA extraction process is bypassed. So the test result is available in 4 hours. So unless and until we are able to do incremental innovation in our testing methodology and the turnaround time, only then we can ramp up the numbers of testing. Of course, currently we don't need it because we are good, but I don't think there is a drastic drop which is deliberate, except the weekend drop which is natural.
Sure. Yeah, of course. I think we just discount that drop that happens every week. But like you said, that even at 28,000 tests per day, we are much higher than perhaps what we were doing in the first wave. And we continue to be at those levels now. Dr. ANOOP, AMARNATH, thank you for being with us and waiting patiently for your turn. Are there lessons here that other states can pick up? I believe some of it is actually being also used and followed even in Karnataka now.
Of course, the best practices are something which we need to inculcate from any which place where these things are done. So say, for example, from as of yesterday, Bangalore has started the model where each of the 28 assembly constituencies, you have a separate war room. And then, the triaging happens over there. And also when it comes to triaging, we must say that it has to be objective triaging. So you see a patient and then the determination of, who goes where, whether they go into home isolation, they get into a COVID care center, or they get into a hospital. So that is what is objective triaging. So the right patient needs to be in the right place. So that's when you can get the optimum treatment. So objective triaging is very important. And one important thing that we need to understand over here is technology is a means to an end. We cannot have technology as a bottleneck. So if you have a centralized command center, that creates a technology haves and technology have-nots. So that's where people start running around, centralized bed management and things like that. So once you decentralize it, you have a local hospital, local center where you can go to, and then the doctor over there assesses and makes a decision about home isolation, hospitalization versus COVID care center. That's the ease of access to healthcare. So I think the learning is from many models. In fact, if I can give you the example, in the first wave, what happened was Karnataka set up the critical care support unit. And what we did was across the 30 districts of Karnataka, it was monitored. All the patients who were in ICU were monitored. And the reason we wanted to do that was to bring down the case fatality rate. And at the end of the first wave, the CFR of Karnataka was one of the least amongst India. So learnings are there everywhere. I think we'll have to take the best practices and then implement it on the ground and ensure that the services provided to the people. And I reiterate this fact again. We should not create technology bottlenecks. Technology has to be a means to an end and facilitate care which needs to be provided to the lowest common denominator.
Yes, and I think that's actually something that we need to look at right from testing to beds allotment and hospital admission to vaccination, where as well this thing needs to be kept in mind. But let me also go back to what was happening when Mumbai was at its peak, and we've come a long way off from. But often the question that's asked and the comparison that is made is about why Delhi had such a massive oxygen crisis, whereas Mumbai didn't see it to that extent. Of course, there were cases here and there where people did struggle. There were a lot of exchange of information happening of where they can source an oxygen cylinder or a concentrator, but nowhere close to the nightmare that unfolded in Delhi and actually still does continue to a grave extent. Why was that, Dr. BHANSALI? Is it that we already had a significant supply within the city, or that we were able to bring in more from surrounding the city? What worked for Mumbai where Delhi struggled?
Yeah, Tanvi, when there was a number of cases was increasing in UK and US, that time we were preparing for this surge or second wave in Mumbai. and we were in that mind that this second wave may be some sort of disasters, so that we should have our adequate oxygen supplies. And that time, our honorable chief minister made that oxygen auditing and oxygen supply. That whole team was there, and with the municipal commissioner also, there was a team who was doing regular audit of the oxygen supply and all the things. And we collected the data from all the private hospital and government hospital, weekly data, that how much oxygen is consuming in the hospitals and how much oxygen may require. So with that time, when we were thinking that there may for shortage of oxygen supply, then immediately government took a decision to stop all routine services, routine surgeries and elective surgeries. And immediately that government was also proactive to discuss with the central government, and they procure oxygen on the time. And because of the teamwork and government was so proactive, so that's why we were saved of this oxygen crisis and this kind of things.
Okay, interesting there, and that you're saying that there was a lot of work, and I'm glad that there was a lot of work that was done much earlier, anticipating a bigger wave and thereby preparing towards it. Perhaps this may be a little too late for many parts of our country now, because there is more and more reports now of oxygen shortage coming in from Telangana, from Andhra Pradesh. Tamil Nadu is now sending an SOS. Goa is sending an SOS. So I think the problem has shifted from the initial cities to just different cities right now, and it continues. A larger question that I wanted to ask, and now I am referring to the IISc report that has also come on what Maharashtra managed to save on and stop by going into a lockdown when it did. Dr. Suneela Garg, there are two aspects of looking at a lockdown. One, that it helps you at that time take a deep breath, prepare yourselves better, given some relief for your overburdened healthcare infrastructure, and then you move on. But it doesn't really take away from the fact that tomorrow there will be more people who didn't get infected earlier who will get infected, the flattening of the curve as it is called. So what's the ideal time that anybody should look at? There are many parts of our country even now where the states or the cities haven't implemented lockdown-like restrictions. At what point should they decide to do that?
I feel that whenever the positivity rate is nearly about 20%, like in cases of Mumbai, they thought of putting the lockdown at the point of 17%. But like in other states, when we are looking for 30% and above, in Delhi, like what we did, or we are doing in cases of Bangalore also, the earlier you respond to a situation, the better is the response. Because first of all, you are able to control your positivity, number one. You are able to manage with your number of cases are also manageable. And third part is that the other supplies, what you are looking at, whether you are looking at the medical part, remdesivir and all that, whether we are looking at the medication part, oxygen part, or overall management part, that is very, very important. So it is important to respond to a situation when you know that you control the situation. But simultaneously, at this point of time, it is very, very essential that when you are imposing a lockdown, you prepare the communities for future. That means they must follow COVID appropriate behaviors, and our testing, treating and tracking has to go on. And we need to also simultaneously have a look at what is our bed occupancy, so that because of if our testing numbers are low, there can be a proxy marker in terms of the bed occupancy. That is also indirect marker of the fact that our infection rates our cases are coming down. So these are some of the cases, but we need to put a kind of we can break the chain of transmission at an earlier stage, so that but at the same time we have to focus with the help of proper information, education and communication with any kind of mass media, so that people should understand that this situation should not bounce back. So this is a kind of only a makeshift arrangement, but then it is very, very important to break the chain of transmission if other methods are failing.
Yeah, actually, Dr. Bansali, maybe you can also come in here, and then Dr. Joshi. When this decision was being taken, and there were series of meetings and a lot of conversation that happened, I think apart from the positivity rate, one other big factor was that you were looking at the pressure on the healthcare infrastructure and how stretched it
Yes.
already was, and the fact that it couldn't perhaps take any more at that point of time.
Yeah, so Tanvi, that our man, that crucial role in our Maharashtra was the task force committee that is headed by Dr. Shashank Joshi and Sanjay Oak. That committee, time to time, they give us a guidance that how to use oxygen, how much oxygen is required. You see, earlier we were using high flow nasal cannula, which was consuming more and more oxygen. So that task force committee guided us that you don't need to use more and more high HFNC because this is consuming more oxygen than this BiPAP machine or ventilator. So these kind of guidance was there in our state. One thing was there. Secondly, when the peak was there, then all task force, that state government, municipal corporation, they called all the private hospital and they said, "Ki this time we are thinking that number of cases may increase or there may be high peak. So we need to increase bed in the private setup also." So private setup in the first wave, they were having only 2,700 bed, oxygenated bed. This time we were having 4,700 oxygenated bed. So these kind of proactive measures were taken in the Mumbai, and that's why Mumbai model is successful. And I feel now we are in declining phase. Today our positivity rate is 5.9 only. So these are the major reasons why this Mumbai model is successful.
Dr. Joshi, would you like to add on this? I remember a lot of these meetings that you had, of the task force with the government and the ministers, the conversations, which were not just about the rising cases, the impact on people and businesses and economy, but also priority being the healthcare infrastructure, because had that crumbled at that point of time, like it did in the national capital a couple of weeks later, it would have been another disaster in Mumbai.
So Tanvi, I agree with Dr. Bansali completely, and we took everybody in confidence. And I think we have to thank our private hospital infrastructure, which rose up to the occasion, the public health system. But what was very important, Tanvi, is that we rationalized oxygen and we had enough beds strength, which was vacant even when we restricted. Because we saw the rate of rise was too fast. It was in a geometric and a ferocious pace. When we detected the ferocity of the wave, we realized that if we don't put a restriction or a circuit breaker or a lockdown, whatever you may call it, we will just not be able to solve the situation. And probably that decision of doing it 2 weeks early and then persisting with it with a little more stringent measures after 2 weeks probably was the game changer. Because though we had buffer capacity and we asked our private hospitals to double up their bed strength, rationalize oxygen use by the oxygen guzzlers which were there, and then did a tight audit and reduced wastage, but took everybody in confidence. I think we have to compliment even our chief minister. He took everybody into confidence, the business community into the confidence, the private doctors into confidence, and he allowed science to dictate a couple of decisions. And therefore, even now, we are test positivity rate has to come below 5%, but we need to saturate our population before we start easing out our restrictions. So I think that was a clear and important thing, that proactively taking people in confidence and taking some firm and stringent measures which not necessarily are popular. I don't think anybody likes restrictions at all, and they were not taken very kindly. But I think ultimately for us, saving every life was important, and that tsunami-like ferocity and the geometric progression of growth, we had to build capacity. So adding those 4,000 extra beds, adding 4 jumbos, doubling up the private number of beds for oxygen, and at the same time rationalizing oxygen and having supplies of medicines. All that was done simultaneously with restrictions. And eventually, all of that has helped. We are just out of the woods, but I would still say we have no time for complacency. We still are in this for a long haul, and we need to be very careful and mindful. So we are fully careful of the facts, and we are still continuously in a mode of discussion and dialogue, and we are observing it very closely and critically.
No, you are absolutely right there. And I want to just take this question across to Dr. Anoop as well. Dr. Anoop, because, Maharashtra did it at a very different stage. And Maharashtra actually did it almost 3 weeks after Karnataka did it almost 3 weeks after Maharashtra had announced its lockdown. Even Delhi moved earlier than that. What were the factors that went into play there? Because if I look at the positivity rate, Karnataka had crossed 30%, and there were days where it was actually more than that. I'm still looking at the average positivity. What were the factors that finally led to this decision in Karnataka then?
I think one clear thing was the positivity rates which were increasing, but I think the biggest factor was the burden on the healthcare system. Availability of beds and availability of things like oxygen and remdesivir were big issues. And I think what we've discussed earlier on, lockdown serves a specific purpose. It gives a breather, ensuring that the healthcare infrastructure is ramped up, and then ensure that healthcare is dished out. So I think what tipped the favor in terms of the lockdown was, apart from the positivity rate, it was the strain on the healthcare infrastructure. But I think going forward, what really needs to be done is, at the end of the day, this is a public health emergency. And there are very objective markers that you need to look at. What is the case positivity rate? What is the fatality rates? And what is the RO numbers? So all these are actual objective markers which should determine by default when lockdown should come in and when lockdown shouldn't come in. And also going forward, apart from these objective measures, what we also need to look at is what is the best treatment modality that we can offer. What we had in the first wave may not be useful in the second wave. We need to add in, we need to improve our armamentarium in terms of newer molecules which we can use. There was a discussion about how to reduce the oxygen requirement. There are certain medications that we have started using in Karnataka which actually reduces the requirement of oxygen. So I think we have to look at from a public health perspective, objective markers to determine when these lockdowns need to happen, streamlining the processes, but more so importantly, emphasizing on what are the standard treatment protocols, and then going a bit more deeper, having an extremely robust genomic analysis, because what you're seeing now is the B1617 strain. And if you also look at it on the ground, you're seeing a lot of secondary complications like fungal infections, which we used to see post-COVID before, but now you're seeing intra-COVID during the actual pandemic, during the active phase of the illness. So a lot of genomic analysis, real-time data with strain is prevalent, where what works on them. I think that's the level of sophistication that we need in India as a public health infrastructure. And that's where we'll be much more stronger in handling these kind of pandemics.
Well, at the rate that we are going, perhaps there will be another way for us to fine-tune all of these. I hope it doesn't come to that, but all science indicators suggest that there may be one more. At least we should learn our lessons from what happened the first time and the second time and prepare ourselves better for the next one. Even now, there are many parts of this country where cases are on the rise, especially some of the northern states which are in a complete disarray right now, perhaps could learn from the systems that are put in place in states like Maharashtra that have helped them control. Timely lockdown was one of those. Even the IISc study says that Maharashtra managed to save 19,000 lives, avoid 38 lakh additional cases because they went into the lockdown when they did. And this should be a lockdown-like restriction should be something that states with high case load should look at. Now, states like Kerala and Tamil Nadu do have a high case load. They also do have a strong public health infrastructure in place. But at some point, the pressure will begin to show there, and that's happening. Pressure is beginning to show even in Tamil Nadu right now when it comes to oxygen, when it comes to availability of beds and the number of deaths that are being registered. Goa went into a lockdown way too late, and now, stories after stories of horror are emerging even from the state of Goa, Telangana and Andhra Pradesh, other states where, of course, Telangana has just implemented its lockdown now and is looking at quite a bit of pain. So perhaps the states need to learn the lessons from Maharashtra, and I'm not advocating lockdown, whatever works for each state at that positivity rate, at that healthcare infrastructure status, but we have to keep in mind that streamlined systems, decentralized war rooms, effective communication, strict implementation of the rules and the curbs, even filing an FIR against the offenders if required, triaging as a system for hospital admissions, effective helplines, all these actually finally help you lower the pain, lower the burden, and give efficient treatment. Thank you so much to all of the panelists for joining us on this conversation.